Welcome to Value-Based Care Insights, brought to you by Lumina Health Partners, a national healthcare consulting firm focused on improving the strategic, financial, and operational performance of provider organizations. On this program, we will explore trends and share valuable insights on how health systems and medical groups can optimize their performance to meet the demands of this increasingly complex healthcare environment and shift to transform the delivery of care. Value-Based Care Insights is hosted by Daniel Marino, Managing Partner of Lumina Health Partners. Daniel has been in the industry for over 3 decades and specializes in shaping strategic initiatives for organizations in areas such as population health, clinical integration, physician alignment, information technology, and data analytics. For additional insights, visit luminahp.com and sign up for our newsletter. Dan, over to you.
Welcome to Value-Based Care Insights. I am your host, Daniel Marino. As we've discussed before, certainly around improving physician well-being, one of the areas that tends to be a big challenge for physicians is the use of their EHR. And it's not so much using the functionality of the EHR. I think as many physicians have gone through the implementation over these past many years, they've learned how to use the system, the EHR, and have learned how to, I think, deliver patient care both within and around the EHR. So that's a good thing. However, the EHR has definitely continued to create a lot of challenges for physicians. And I think those challenges have come in a couple of different areas. I think one is that physicians have and continue to spend a lot of time in their EHR documenting activities, working through messages, managing alerts, and so forth, all outside a lot of the direct patient care activity that they have either within their clinics or with patients. And that creates a lot of challenges and frankly, a lot of dissatisfaction for physicians. I think the other thing that we see here too is because as we think about value-based contracts, there's a lot of performance outcomes, indicators, and so forth that are really dependent on the EHR. We extract all of those data points, we extract all of those outcomes from the EHR, and we use that to not only track the care that we're delivering to patients, but we evaluate the performance of our value-based contracts. So if information is not entered appropriately, then physicians may not necessarily get credit for the good care that they are providing. So I'm really pleased today to have a soon-to-be strong physician builder in Epic, somebody who we worked with for a number of years, Dr. Kim Furry. Dr. Furry is a board-certified orthopedic surgeon. She right now is going through a lot of Epic training. She's worked on Epic for many years and is becoming an Epic builder, really to support some of her colleagues and with the idea that really we're going to enhance a lot of the functionality of the system. Kim, welcome to the program.
Thank you, Dan. It's great to be here.
So, Kim, you worked on Epic for a while, and you've heard probably a lot of the challenges and the complaints and dissatisfaction from your colleagues. From your perspective, what are some of the leading challenges that you see from physicians that really is kind of standing in the way of them practicing efficiently, either through Epic or another EHR?
I think many of the challenges are basically the time that you spend in an EHR, and it seems like it depends on how you utilize the EHR, but some physicians are spending, concentrating on the EHR during the clinic visit as well. And instead of paying attention to the patient, and this is a complaint you get from many patients as well, that the doctor's just looking at their computer and typing away and not really paying attention to me. So that's a big challenge, I think, is that patient interface. And the time is a big one. I think taking that time up front, we may talk about this later as well, to customize it so that it works for you. The EHR can be a big burden, but it can also be a big time saver if you take the time to customize it for
Right.
your workflow.
Yeah, I definitely think that as you think about creating efficiencies in the care delivery model, the EHR can certainly help, right? So if you can better connect the physician with their clinical assistant, obviously that helps. If there's particular integration that occurs with the specialist, that would help. If there's integration that occurs with maybe the lab result, right, or some other radiology report, I think that would help. But it is really dependent on that integration. And I sort of feel like we're still at the point where that integration is really not efficient.
No, you're right. It's not efficient. And I think it also depends on the system you're in. Many people have, it's a contained system like Kaiser or something like that, where I'm getting my labs in a Kaiser lab. Geisinger probably is similar. I don't know exactly. But all your specialists are in Kaiser. All of your labs are probably in Kaiser. And that's probably more integrated. Where I am in Colorado, it's a 20 hospital system with a few in Kansas, a few in Utah, and the rest in Colorado. But we get our labs at very many different places. And so those getting imported into our EHR is not very efficient, and they don't communicate so well. And the same with radiology studies and imaging reports and things like that. Getting those uploaded into our system so we can look at it directly is burdensome on the staff, and not always doesn't always occur.
Right. Well, and I think tying that then in with even the in-basket management also is a big challenge. Early on in probably I want to say the mid 2000s, and for about 10 years after that, we did a tremendous amount of EHR implementations, and we really focused on incorporating physician super users to design the system that really works well for the physician's practice style and basically integrates a lot of the efficiencies that are important. But I can remember it was probably about 4 or 5 years ago, I was talking to one physician, and he brought up an interesting point. He said, Dan, in-basket management is probably the biggest challenge that I have right now. It's probably adds 3 additional hours to my day. And I was like, wow. I mean, that to me was unbelievable. And, physicians put in a lot of time anyways, but then adding in 3 more hours to their day clearly takes away from their personal time, right? Time that they could spend with their family, and just real challenge to keep up.
That's huge. I think previously, so I've been on Epic for 8 years now. And when I first started practice in 2000, the MA would come to me at various points in the day with a number of messages, and I would respond to those messages, and then boom, that took minutes at the most. And it was done. My part was done. Occasionally I had to follow up with calling a patient about something. But for the most part, she'd ask me the question, I'd answer, I'd give her an order or whatever, call in this prescription, she would call it in. I wouldn't have to sign off on anything. And that was very efficient. I think, and remember that 3 hours that you sit on in-basket management at the end of the day, that doesn't include all the other documentation.
Right.
and other work that he had to do. It was administrative or chart review or
right.
notes written for school release or whatever it is, right? Authorizations for.
Yeah. So when you add in all of that, it's like, oh my goodness, if you have a 6 or 8 hour clinic, you're probably spending another 4 hours at least on top of that.
Exactly. And so I think people can build, there's a couple things I have to say on that. One, about 3 years ago, probably our system, my healthcare system, the medical group, we kind of went through and created a bunch of different rules on what we might want to keep and not. And we deleted like hundreds of thousands, maybe even a million. I can't remember the number, but it was hundreds of thousands of in-basket messages that were sitting in people's in-baskets to just get them out there and try to clean it out and start with a cleaner slate, right? And then what really needs to go to the physician, what can go to an MA or a nurse. We try to create some triaging capabilities there. And then if you take the time, again, it's taking the time up front, which is going to save you a bunch of time on the backside to build quick actions so that, when you get an abnormal lab, I'll just give one for me. I do an orthopedist, I do some osteoporosis care and fragility fracture care. And so I would check vitamin D levels, and I had, if patient's vitamin D level was such and such, no change. So I'd have a quick message. I just had to click one button, and that message would go to my MA, tell them to keep taking the same vitamin D level. If I wanted them to go up to 2,000 or 5,000 or 10,000, one button for each of those, it would go to the MA, it would sign the note, and the MA would call in that prescription or call in that recommendation, right?
So it sounds like a lot of the efficiencies that you've experienced really comes down to how the system was built.
Somewhat how the systems was built, and then those quick actions are how I built them, right?
Yeah.
So the system allows that. My system is built such that I can do that. And, EHRs are not one size fits all. You buy the base, you may buy different modules for orthopedics, for oncology, for cardiology, whatever it is. But your system has to buy those modules. But when you buy it, it's still kind of like the basic build.
Right.
And your own system builders will customize that customize it and improve it to improve the efficiencies.
Right. Yeah. So you just can't get the module, right? I mean, you really, from what I hear you say, you really need to take the time to build it correctly. You really need to take the time to figure out how you can create efficiencies in a new care delivery model integrating with the EHR, not just buy the module and hope it's a panacea.
Absolutely. And it's not just you customizing it for your workflow, your system has to customize it for your system as well. And I've been on so Epic has, so that dissolves, or that gives you an idea of who I work with for my EHR. But Epic has these steering committees and steering boards, really, is what they are, for the different specialties. So for the last 3 years, I've been on the steering board for orthopedics, and that's a group of orthopedists from around the country. And we give Epic ideas on what things they should build. And so there are some things that we've all customized in our own institutions, but what we're trying to import upon them is the importance of building some of these things for the system itself, so that when somebody purchases the bones component, then some of these things are pre-built into that bones component, and the system itself doesn't have to reinvent the wheel.
Right. Well, if you're just tuning in, I'm Daniel Marino, and you're listening to Value-Based Care Insights. I'm here today talking with Dr. Kim Furry. We are discussing both the challenges and some of the opportunities around maximized performance of your EHR. And Kim, so as you're talking about the build, in my mind, I guess it comes down to two things. One, the system needs to be built appropriately so it does create efficiency. So you're not actually putting in a lot more time, but you're creating some efficiencies both to improve patient care and obviously to make it easier for the physicians. But I think the second part of the build is around how we're capturing the data. I can remember early on when we were doing our EHR implementations, for instance, if we were capturing an a hemoglobin A1C result of a patient, one, the naming conventions were all different. Two, there were probably 2 or 3 different areas where we can put it into the EHR. Has that resolved itself, or is that still an issue?
I think it's still an issue. I think the problem is we can only find the data that's in this discrete data field. So even if I'm writing a note, right? Say I want to do research on total knee recovery and range of motion, or whatever it is, right? Whatever I want to do for total knees. Unless I write my note in what's called Note Writer and I put the range of motion in Note Writer, I will never find that range of motion. So if I just have a smart phrase and I dictate the range of motion at this visit, or I type it in, I'm not ever going to be able to retrieve that data. Likewise, many of the quality metrics that we need, especially from a hospital standpoint, it's largely related to, it revolves around nurse, it's nursing dependent in their flow sheets. Right. And so if I say in my note something about a CAUTI, catheter associated urinary infection, but it's not in a flow sheet somewhere, that's never going to be
Right.
caught.
So even though you may be doing it, even though you may be performing it, you're not capturing it appropriately. So as you start to extract the data, you're not going to know, or you're not going to be able to get the results. You're not going to be able to get credit for the work you're doing.
Exactly. Garbage in, garbage out. So if you're not tracking it correctly, and have it, mining the chart notes is super hard. Mining the discrete data fields, much easier.
Mm-hmm.
But some of that stuff there either doesn't exist a discrete data field, or it's missed, or it's put in incorrectly, or whatever. And so data will be missed.
Well, and one of the things that I've heard you say a number of times is you really need to build the system to ensure that you're trusting of the data. And many physicians struggle with that, right? So when you pull reports, they don't believe the reports. And I think some of the reasons why they don't believe the reports is they feel like, well, it's not a good representation of the care that I'm delivering to the patient.
Right. That's exactly true. And even if you look at surgical time, so, say my ACL time is on average 55 minutes or something like that, right? And we're trying to create my surgical block time, but in reality, I put in a request for an ACL plus a medial meniscal repair and a lateral meniscal repair. So that takes my 55 minutes for each one of those and creates my block for that case at what, 1,500 minutes, right? Or 150 minutes, right? Which is really not the case, because that doesn't include everything for each of those cases. And so when they try to tell you that this is your Olympic averaging and we're going to schedule this case for 3 hours, you're like, no, it's not a 3-hour case,
Right.
That's just one little example of where the data misinforms downstream effects, and then it has a big problem there.
So when you're working with physicians, and I know you're just starting to get into this, and I give you a lot of credit for now diving into a lot of the Epic training and becoming an Epic builder. I think that's fantastic for you and the organization and your colleagues. In your mind, where do you see starting, or let's say better integrating with the physicians or with the system to enhance some of the build?
I think some of the things that I'm learning, and to be honest, I don't know how much of this goes into the background, like for our BPA warnings and flashes.
Mm-hmm.
There are ways that you can build this that it looks at, if this and this, but not that, then I'm going to flash, right? I'm not going to just flash for everything that doesn't have a TSH in the last 90 days. I'm going to flash if it's been ordered in the last 5 days. I'm not going to flash it because it's been ordered. However, next time I come up, if it hasn't been delivered, so say I come up in another 15 days and it hasn't been, the patient hasn't gone and got their TSH, it will flash.
It will flash, yeah.
It will.
So maybe the notifications are certainly one area, right, where you can kind of see some improvements. Notifications,
building of order sets,
can
be improved as well, and become more efficient. Pre-checking some of the things and only showing the pre-check, having things so that they're not all fully expanded, so you don't have to scroll, so that they're all collapsed. And if you want to go into this particular order or this part of a note, like our SOAP notes, for our build, the subjective, objective are always, and plan are always collapsed. So when you want to read the subjective, you can just open that up, and the same for the objective or the assessment plan.
Right.
So less scrolling, less clicking, those types of things.
Do you, so when I was working with one of my colleagues not too long ago, and he was in a similar role, kind of an Epic physician super user, one of the things that he really focused on was reducing the clicks, the unnecessary alerts. And in some cases, he actually turned some of the notifications off for the physicians. Is that something that you see as a benefit that other folks should look into, or is it really a case-by-case situation per physician?
No, I think all systems should look at it.
Mm-hmm.
I think there are alerts that shouldn't fire. I think one of my pulmonologists said in order to kind of finish reading a sleep study, or it wasn't a sleep study, I don't remember what it was, but he had like 30 some clicks to do that. And when I
Wow.
mentioned it to one of the builders, I wasn't a builder at that time, and they were able to get that way down to I think less than 10.
Yeah.
So what we don't know either. And so people have to bring some of their issues to us, and then we can optimize some of that workflow as well over time.
Yeah. Well, and again, I think to have somebody like you that is an epic builder that begins to get trained and really you sort of build those internal capabilities. I think that's so important. Many organizations, and we used to see this all the time when we were going through our EHR implementations, you don't know what you don't know, to your point, right? So you don't know what the system can do for you to really enhance your clinical workflow. So a lot of times what physicians do or what organizations do is they build it around what they know, which is either a previous EHR that wasn't very efficient or maybe their paper environment. And even though many organizations have been on Epic for 10, 20 years in some cases, I don't think they've really gotten past that. I don't think they've really gotten past the point where that efficiency has really been built into their clinical workflow using Epic or Cerner or any of the EHRs as a tool to really enhance patient care.
No, I agree completely. I think you can make the order sets, you can make the BPAs somewhat dynamic, right? So if somebody's allergic to penicillin and you have this order set and it recognizes that the patient's allergic to penicillin, it's not going to give you the penicillin options, it's going to give you the alternatives and say that there's a penicillin allergy and these are the alternative antibiotics.
Right.
If they're not allergic to penicillin, then that's not even going to show up. They're just going to be given the option for penicillin.
Right. And so the system, if I can try to, then the system becomes intuitive, right? To
correct.
what's occurring with the patient, but also then is better informing the physician.
Correct. Exactly. But you have to build it such that it does those dynamic, look at the charts and recognizes something, and then
build the algorithms and all of that. So for our listeners today, are there in your experience, are there a couple of quick wins? Are there a couple of key things that maybe folks should be focusing on that would really help the physician's efficiencies and really maybe the satisfaction with the EHR?
Yeah, I think so. I think taking the time to customize it for yourself. I know it takes time and nobody wants to do that at the end of a busy clinic. What I would say is when you first start on an EHR is a time to start that customization process, because most of the time when you transition to an EHR, your clinic schedule has been shortened quite a bit to give you time to kind of work through that. That doesn't last for very long, and most people are just trying to find their way through the woods and the weeds at that point in time, and so they don't take the time. But as quickly as you can, and even if you haven't done it, starting now, take 30 minutes a week and take your top diagnosis that you think, whether it's CHF or knee arthritis or whatever it is, and create a plan, create a patient information sheet, create a physical therapy order for your PT, whatever it is, create an order set that's customized for your total knee pre-op and post-op. Most of them come with a pre-op total knee and a post-op total knee, but you need to customize it for your self. You need to pre-check the buttons that you want checked. You need to put your name into the physician. You need to put your hospital into the location. And if you take that half hour once a week for your top 10 diagnoses, in the course of 3 months, you're going to have most of it built, and that's going to save you hours literally on the backside.
Yeah, I love that.
Yeah.
I really do. I think that's great advice. I mean, take a look at your top diagnosis codes, take a look at and really focusing even 30 minutes a day, probably time well spent to invest in improving a lot of the activities there. And then what about the data, Tim? Real quick, is there some things that organizations can do to run some reports that validates the data that they're putting into their EHR reflective of the care that they're delivering?
I might push that question back on you.
Well, I would say yes, to tell you the truth. We negotiate a lot of the value-based contracts and work with a lot of the payers in the organization. So I would say yes, do your checks and balances to make sure that, the data that's being entered is clearly reflective of the care that's being delivered. So I definitely think that that's the case. Well,
yeah, I think it's the case, but how does that occur? That I don't know how that occurs. I don't know how we can validate some of that data without a lot of manual work. So,
well, I think you've got to do some, right? You've got to do some spot checks with
absolutely.
EHR and with the notes. Well, Ken, this has been fantastic, and I know it's a topic that is top of mind with many of our listeners, particularly our physician listeners. If anybody has questions for you, any thoughts, any ways that they can get a hold of you?
Yeah, absolutely. Email is probably the best, or text me, call me. Either of those are fine. My cell number is 970-903-7540. And my email is kimfurry, KIMFURRY @centura.org.
Wow, that's great. Well, Ken, this has been a great discussion. And again, I think congratulations to you taking the initiative on moving forward with these certifications and becoming a physician builder in Epic. I think you're going to be great. You clearly have the passion for it. So thanks again for coming on the program. Really appreciate it.
Thanks for having me. It's been great.
And thank you to all of our listeners for tuning in today. Really appreciate it. Until the next insight, I am Daniel Marino, bringing you 30 minutes of value to your day. Take care.
Are you at a crossroad with value-based care? Do you need to chart a future strategy or improve your organizational performance? Visit us at luminahp.com to learn more about our consulting services and leadership development programs. Also, you can sign up for our newsletter on our website and follow us on Twitter and LinkedIn. For more information about value-based care insights, visit the programs page on healthcareradionow.com or luminahp.com. Join the conversation using our hashtag VBC Insights. We are Lumina Health Partners. Thank you for joining us today. Until the next value-based care insight, stay well.